This pandemic is something that in public health we have thought about and in many cases trained for a long time. And so in March of 2020, when the world changed, our practice had to change. And so people really leapt into action to think about how we make sure that patients can still get the care that they need.
Community health centers rose to the occasion to provide critical access to primary care services, even through the pandemic, and to assure that their staff could also remain safe in the face of increasing spread and a lack of PPE in some cases. So 43% of health centers provided telehealth before the pandemic. During the pandemic, almost all of them. They increased to scale, moving from over about 500,000 telehealth visits to over 28 million in the course of the pandemic.
One of the resources that our office used to disseminate this information was Telehealth.hhs.gov. It's a resource for providers and patients, and it includes best practices, billing and policy information, funding opportunities, research to help the providers during this transition.
Telehealth has long been a tool that our grantees in the Federal Office of Rural Health Policy have used in order to ensure that rural residents have access to healthcare services. So it was no surprise to us when COVID hit and the grantees, even if they weren't using telehealth, they really did pivot in order to bring telehealth services into their work plans and keep those services going for their patients.
During the pandemic, we offered $15 million in grants to 159 different organizations. We also created a number of flexibilities for our National Health Service Corps and our Nurse Corps clinicians so that they could continue to serve in the field and support telehealth.
Specifically for the Ryan White HIV/AIDS program, one of the first steps that was necessary was that we would do an inventory to capture where people were, especially our providers, as far as their capacity to service clients. Because of course, with this population, HIV suppression is a high priority, and we wanted to make sure that our clients were in a space where they felt safe and also where they could access the care in the absence of actually coming into an office.
I certainly hope that we've seen that we've opened this door to telehealth. We don't want to close the door and go back. Telehealth is certainly not the answer to everything, and so there are many examples of where you just can't replace an in-person visit. But there are also many examples of where telehealth really is a great fit to meet patients where they are. For us at HRSA, as we think about our mission around health equity, it helps us address those barriers that patients face. It may help us address social determinants of health, like access to care. Transportation is a huge barrier, particularly for some of our families who live in remote or rural areas.
I think now that our grantees and our rural communities have seen how much more access they can have through the use of telehealth, I don't think they're going to want to go backwards. I think they're going to want to keep implementing telehealth services as one tool to help continuing to make sure that our rural residents really are getting the care and access that they deserve.
Here in the HIV/AIDS Bureau, we are also charged with working towards ending the epidemic. And as part of ending the epidemic, I think the strategies that we're pulling in that are related to telehealth and other strategies are needed and necessary to make the changes that we need to make to be able to end HIV by 2030.
And so HRSA was able to award $50 million to health centers to figure out how to optimize virtual care, with a special focus on some of the hardest to reach and most disproportionately impacted populations, individuals experiencing homelessness, migrant seasonal agriculture workers. So they're going to figure out, how do you optimize this and sustain virtual care so that it's there into the future to serve the underserved communities.